Latest guidelines on aneurysmal subarachnoid hemorrhage. Epidemiology and clinical importance. Intracranial aneurysms occurs in 3% of adults. More common in women, rupture causes aneurysmal subarachnoid hemorrhage. About 50% of patients are younger than 50 years. Most of them are women. Mortality is very high, that is approximately 40% die within 3 months. Only about a third of patients regain the functional independence. But these survivors will frequently develop memory impairment, reduced concentration, fatigue, depression, and emotional and cognitive dysfunction. Major complications after aneurysmal subarachnoid hemorrhage. First one, rebleeding. Risk is approximately 40% if the aneurysm remains untreated. Highest risk is in early period after the rupture. Second one, delayed cerebral ischemia occurs in 20% of cases due to reduced blood flow due to vasospasm. Third one, hydrocephalus occurs in 25% of cases. It may require CSF diversion. Strong evidence-based recommendations. Antifibrinolytics are not recommended. They do not improve functional outcome despite reduced rebleeding risk. Nimodipine. All patients should receive oral nimodipine. Reduces the risk of cerebral ischemic injury and poor outcome also are reduced. Other drugs which are not recommended are statins, magnesium sulfate, endothelin receptor antagonistics. Securing the ruptured aneurysm. Timing. Aneurysm should be ideally treated within first 24 hours. Preferred treatment in patient with good clinical grade and milder deficit. When both options are available, that is endovascular coiling and clipping, the coiling is always preferred over clipping. Microsurgical clipping, intracranial aneurysm. Here we can see vascular clip applied to the aneurysm neck. Here we can see various methods of reducing the risk of rebleeding. First one, clipping. Second one, wrapping. Third one, clipping with the coil. Fourth one, using bypass. Introduction of, here you can see endovascular coiling, introduction of catheter into the aneurysm, insertion of coil into aneurysm via catheter, aneurysm packed with the coils. Multidisciplinary decision making. Treatment decision should involve at least one neurosurgeon and at least one neurointerventionalist. The goal is to choose the safest and most durable treatment. Blood pressure management. Before aneurysm securing, BP lowering may reduce the rebleeding risk in severe hypertension. We should use slow controlled reduction and short acting antihypertensives. And we should avoid sudden hypotension. Endovascular techniques. For aneurysms unsuitable for simple coiling, evidence remains insufficient for procedures like stent-assisted coiling, flow diverter devices, intrasaccular devices. Balloon angioplasty, it is reserved as last line rescue therapy. Temporary stents are not supported by sufficient evidence. Delayed cerebral ischemia management. If neurological deterioration occurs, consider induced hypertension only after aneurysm is secured. We should ensure adequate fluid administration first. Endovascular vasodilators may be used in severe vasospasm. Coming to monitoring recommendations, the useful imaging modalities when patient worsens are CT brain and CT perfusion. The not routinely used ones or not routinely recommended ones are invasive multimodal monitoring, EEG monitoring, complex monitoring systems because the benefit remains unclear. Hydrocephalus management. Acute hydrocephalus. Drainage is recommended when there is reduced consciousness present. Drainage method depends upon imaging findings and presence of intraventricular blood. Chronic hydrocephalus, long-term CSF diversion or shunting is recommended when temporary drainage is no longer safe. Recommended treatment center. Patient should be managed in specialized neuro ICU. Centers should treat more than 70 aneurysmal subarachnoid hemorrhage patients per year or more than 35 patients per year in remote regions. Operators should treat more than 30 intracranial aneurysms per year. Follow-up imaging recommendations. After coiling, imaging at least once more than or equal to 12 months after the treatment. After clipping, usually no long-term imaging is needed if the complete occlusion is confirmed within 6 months. Long-term follow-up is needed in case of partially occluded aneurysms, flow diverter devices, intrasaccular devices. Screening for new aneurysms. High-risk patients should undergo imaging every 5 years. High-risk groups, younger age group, positive family history, autosomal dominant polycystic kidney disease.